Hello. So many friends. First of all, I'd like to thank the Manos. And Manos in Portuguese is brothers. So thank you for a kind invitation. As you can see now, me and Manos Antojanakis, we come from a long time. We were quite younger in this picture. So this is a video. Please turn on the video. So this is my team. I must say I'm an Artex consultant. So we need definitely to know where to, when we should do the remplissage, and we have to calculate, as has been said, the bone loss of the glenoid and the bone loss from the heel sacks. We ourselves have done a work on this how to measure the heel sacks lesion, and of course we favor the on-track, off-track concept. As a rule of thumb, we use the Bankart and remplissage in patients that have more than 20% of loss of glenoid and have a non-on-track lesion. If I see this, which is an off-track lesion engaging, for me it's a bone block procedure, so I don't proceed with remplissage. If it is like that, which is a non-engaging during the arthroscopic, it's a non-engaging heel sacks lesion, then I will consider a remplissage in this patient. And we'll go from here, and now I will explain to you how do I do my remplissage procedure. One of the things that I do is that I work from an anterior view. And I don't look to my shoulder from the posterior view when I want to do this. So I work like that with two portals, and I search my posterior labrum, and I use also a posterior cannula in order to be easier for me. So this is my anterior view. I'm looking from the anterior superior portal and working from the anterior inferior portal. I use this kind of instrument in order to detach my labrum. As you can see, I have a clear view of my labrum. I'm a clear view of my bone, so it's easy for me to understand where should I cut, where should I disinsert my labrum. As you can see, this patient has a bone loss of the anterior glenoid, but as I tested it previously and I've shown to you, this is a non-engaging heel sacks lesion, so I'm going for a remplissage procedure. After clearly detaching my labrum, I'm going to abrade my anterior surface of the glenoid, and then I pass to the posterior part. I introduce my cannula, then I abrade my heel sacks lesion. I'm not too aggressive because I don't want to do a better heel sacks lesion. Then I use an anchor. You can use whatever anchor you want, but be aware that in young people, this part of the bone is very hard, so be aware not to break an anchor, and do it with a strong anchor. Then, as you can see, I do for the beginning a lazy stitch with 2 strands, and I put my cannula in the back of the capsule, so cannot see the labrum, the cannula here. My cannula is outside the capsule, and then I repeat my gestures in order to make like a parachute with my strings, as you can see here. I try to be very careful when suture managing. As you can see, I'm going around the other white one in order not to be tangled here, and in order to have sliding knots at the end. Sometimes it doesn't happen, but you have to be careful on that. So I repeat, and I want to have this kind of aspect at the end of my preparation of the remplissage. Then I go again to the front, and in here I don't need again to be in the anterior portal, and I do my Bankart procedure. So I prepare my remplissage before my Bankart, and then I do my Bankart here with the knotless anchors and using tapes instead of strings in order to get more contact with my bone, and it has been published before. Perhaps it's less painful when we use tapes instead of strands. Then this is a common procedure for a Bankart. As I told you before, my remplissage is already prepared, and after, when I do my labrum procedure, I will go back again to the remplissage, so I'll have to change my portals, and I'll have to go to my anterosuperior portal again. As you can see, I try to get, as you mostly do, a good bite of my labrum. I try to do soft tissue bumper effect in order to have a good reduction of my labrum. And as you can see, I always like to have some blood flowing, because this is for me the idea that I had done a good liberation of my labrum, and I have biology in order to get healing of my labrum on the anterior part of the glenoid. Here, those devices have the advantage of not having knots in the front of the shoulder, and maybe be less aggressive to the head of the shoulder. Then we'll go as many anchors as needed. I think if it is 2 that is needed, it's 2. If it's 3, it's 3. It's 4, it's 4. So I don't really believe that you have to have definitely at least 3 anchors. I think it depends on the way of the lesion it is, and the way of the procedure that you need to do in order to have a good healing of your labrum. So I finished with my Bankart, and now I will change my portal again. So I'll go for the superior portal, and then what I want to do is to make a tenodesis effect of my capsule and then my infraspinatus in the heel sex lesion. So now I'm doing sliding knots with those with my strands of the anchor, and I normally begin with the one it's more inferior. If it is the blues, that is more inferior. Then I check my my head balanced in my shoulder, and then it's the end of the procedure. This is the effect that I wanted to have at the beginning. As a post-op, what we do, we use this small cushion in order not to stress our reconstruction of the posterior part of the shoulder. We'll do it for 3 weeks, then we'll begin from 3 to 6 weeks isometric exercises and passive motion exercises. I would like to call your attention for our course that we'll have in Cascais, Portugal, with a wet lab in the 10th and 11th of July of 2020, and thank you very much for your attention.